Cancer treatment is all about time, how early it's detected, how soon are you seen, while 2/3 of the targets for that treatment are set to be scrapped in England. So what's likely to be kept? Diagnosis of cancer within 28 days, referral within a month, and urgent treatment should start within 2 months. But Cancer Research UK described this year as the worst on record, with all the major targets being missed. For Shirley, when she feared her breast cancer returned during COVID, the wait to be seen added to the stress she was already under.
It's the most awful time waiting for that appointment, waiting to hear some news. At the minute we wait 2 weeks for an appointment, but then you wait 2 weeks longer to get results of any tests they might have done, and really that's long enough.
The Health Secretary insists reform would make care better.
Any changes that are made will be those driven by clinical experts in the cancer field and will be done in conjunction with the leading cancer charities. But what we're focused on is outcomes. What is the best way of getting the highest survival rates?
Labour says the government are dodging accountability.
With this government, what you've got is targets that they repeatedly fail to hit. And now what they're doing is moving the goalposts, and even where they're keeping targets after this streamlining, their targets they're still not hitting.
Professor Pat Price is a leading clinical oncologist who's tried to meet with the Health Secretary without success.
Simplification of targets may be useful for patients, but the whole point is we still need to be accountable to what we do. And importantly, this is the biggest cancer crisis of my lifetime. Changing targets is not going to get things better. We've normalised failure. We seem to accept that patients aren't treated on time, and that's not acceptable. Sometimes I feel like a lone voice. We should be absolutely screaming and shouting about this.
The Prime Minister has the NHS as one of his 5 key pledges. He visited the centre in Nottingham a few months ago with the Health Secretary. The government has also set out today a strategy for 6 of the main health conditions in the UK. The focus is on catching problems early and treating conditions before they get bigger. Well, that's the plan, but in practice, health leaders ask how it will be possible to do that, with pressures on staff and resources. Junior doctors are on strike now, asking for a 35% rise in pay. Their union says it's to make up for years of underfunding. Consultants too are soon to join the picket line. While the government's planned a series of health announcements this week, rushing to rescue a service in need of help, many who work within the NHS say the government's diagnosis is surface and doesn't go far enough to save a system they believe is failing.
Well, I'm joined now by 2 cancer specialists, Professor Carol Sikora, who's in our London newsroom, and Professor David Sebag-Montefiore, who's here in Leeds with me. Professor David Sebag-Montefiore first. The Health Secretary says this scrapping of these targets has been called for by clinical leaders. Have you been calling for it?
I haven't personally, but there's been a consultation process across a whole range of stakeholders. I think it's important to recognise that these are revisions of the actual target process. Previously 9 targets and focusing on 3 key targets.
So it could be a streamlining, could be helpful.
So I think there are some positive aspects to streamlining this process because it was quite complicated to follow all 9. We also need to bear in mind that these targets were originally set up in 1999, so actually refreshing them and actually making sure that the targets are right is an important task.
Well, Professor Carol Sikora, is this a welcome refresh, a welcome reform, or is it an admission of failure?
I think it's an admission of failure, although, as David says, there are some advantages in the new target, because that's what matters, it's the outcome. If people get treated within 62 days of being diagnosed as having cancer, they're going to have a much greater chance of cure if they're not delayed by anything. The problem is that, and Pat Price again gave it, the targets were made up at a time in 1999 when we didn't have the facilities to speed people up. Even if the GP knew they had cancer, that's how the 2-week wait arose. And what's happened to the 2, it was all right for the first 10 years, and then gradually it drifted down. And as of last week, the data for the 2-week wait is really quite appalling. If you were in America, you'd sue if you couldn't get an appointment to have what you might have cancer, getting it sorted out.
Right, well, let me put that to David here in the studio. I mean, do you agree that some of the existing performance against existing targets is appalling? I mean, how would you characterise the state of British cancer care right now?
So as far as the targets are concerned, they are clearly demonstrating that we do have delays that are longer than we would want. We're all very aware that people who are suspected of or are diagnosed with cancer want to be diagnosed and treated quickly. We have been through a very considerable upheaval with unprecedented changes with the COVID pandemic, a recovery from that, and we also are aware that actually cancer is going to rise in terms of its incidence. So the actual percentage targets that actually are going to be attached to these three key objectives are yet to be announced. But as Carol said, I think we do need to recognise that actually we want to do better. But these are an indication of the current situation. They are an indication of the problem, but we need to look at the solutions.
Well, Carol, is one of the solutions just simply more investment, especially as David was saying, the incidence of cancer is going to rise in the next few years?
Yeah, two things you need, equipment and people. People actually are more important than the equipment. And if you think of the modalities of cancer treatment, surgery, radiotherapy, chemotherapy, they're all areas where there's a huge shortage of people. Operating theatre technicians, for example, radiographers that man the radiotherapy machines, huge shortage. And it's an international marketplace. They can command double the salary in the Gulf or in Australia. So we have to think much better about workforce planning for cancer. I've seen endless reviews on it, and I know David has too, but nothing seems to happen. And what worries me, changing the targets allows you to reset the bottom line, basically. You won't know if really much has changed. You set a target, which you keep, and then you watch what happens as you recover from the backlog. I think there are two problems at the moment. One's the backlog, which we've already alluded to. We've got to get rid of that before we can get into a steady state. And the second thing, even before the backlog, we weren't in a steady state. We're gradually getting slower and slower because of capacity issues.
Well, you've mentioned one way of clearing the backlog. You've talked about these Rutherford cancer centres lying idle. I know you've had a financial interest in those centres, but you wrote to the Health Secretary proposing the private sector be brought in to clear this backlog. You didn't get a response, did you?
No, you don't expect a response, like Pat Price didn't either. I think it's interesting. The private sector runs about 26 places with radiotherapy and about 60 places with chemotherapy. And it could be brought in. There is spare capacity in the private sector. I prepared a plan for this during the pandemic for the chief executive of the NHS, Simon Stevens, then. But he was interested in doing something, but the problem was surgery then. Now it's not. It's the downstream processing of patients that we know have cancer that just can't get started on treatment quickly enough. So private sector would be great to do that.
David, is that part of the answer, in your view, pressing the private sector to help clear this backlog?
I think the key part of the answer is actually a coordinated cancer plan. We absolutely need to identify the key areas. As Carol said, the workforce is critically important.
But that comes down to money, though, doesn't it?
It's not only about money, it's actually about training the right people and actually expanding that training pipeline. There are actually research initiatives directly planning to do that, not only in terms of doctors, but also in physicists and healthcare professionals. So we really need to plan the workforce of tomorrow and the projections based on cancer. We need investments in equipment, but there is some light at the end of the tunnel here because there are advances in research. And we actually need more investment in research as well that can allow us to do things faster, more efficiently and cheaper. For example, at the University of Leeds, I see really exciting changes around miniaturized robotic tentacles that can reach parts of the lung and the pancreas that normal instruments can't reach. NICE announced last week that 7 artificial intelligence solutions can be used for radiotherapy treatment planning in the NHS as a draft guidance.
Well, it's good to end on a more optimistic note. David Sebag Montefiore and Carol Sikora, thank you both very much for joining me.